Good afternoon. Dr. Saba is our first speaker of the afternoon. He's Professor and Vice Chair for Quality and Safety in the Department of Hematology and Medical Oncology at the Emory University School of Medicine. He serves as co-director of the Head and Neck Cancer Multidisciplinary Program at Winship. Dr. Saba is a recognized expert in immunotherapy for head and neck cancer. His work has focused on translational research and the study and development of novel therapeutic agents and modalities for head and neck and esophageal cancer. Dr. Saba earned his medical degree from the American University of Beirut Medical School. He then completed his residency in internal medicine at Tufts University in Boston and a clinical fellowship in hematology and oncology at Brown. He also completed a bone marrow transplant fellowship at University of Toronto Princess Margaret Hospital in Toronto, Canada. We are pleased to have him here this afternoon to speak on multi-kinase inhibitor therapy for RAl-refractory papillary thyroid cancer.
Good afternoon, everyone. It's a pleasure to be part of this symposium. Thank you, Amy, for spearheading this effort. I'm going to talk to you today about the use of multi-kinase inhibitors or tyrosine kinase inhibitors in radioiodine refractory papillary thyroid cancer. This is my disclosure slide. So as you all know, thyroid cancer is a heterogeneous disease. And when we diagnose thyroid cancer, most of the cancers that we diagnose are actually papillary thyroid cancer, hence the importance of this part of the symposium. However, we have to remember that other subtypes also exist. The very interesting medullary subtype, anaplastic subtype, currently with the recent advances in targeted therapy, is very interesting to a medical oncologist. But let's focus at this point on the differentiated thyroid cancer, namely papillary thyroid cancer, and we'll discuss the others in subsequent parts of the symposium. When we look at papillary thyroid carcinomas, it's important to understand that this is a heterogeneous group of disease. And this is not a heterogeneous group of disease just molecularly, but also histologically. These histologic subtypes may have bearing on how the disease behaves. And so we are clearly dealing with a basket of different diseases. Certainly some of these diseases do end up having some anaplastic features, and those basically are treated somewhat differently as a more aggressive cancer. And therefore, we have to pay attention to all these variations when we treat these patients. When we go to the follicular thyroid cancer, this is the second most subtype. It accounts for about 13 to 15% of all thyroid cancers. It tends to disseminate hematogenously with metastases to bone and lung, and is characterized by mutations in the RAS gene, as well as PAX8, PPAR gamma mutations. So this is the spectrum of follicularly derived thyroid cancers, from papillary to follicular. You've probably seen this slide or this slide before, and you can see that when there is progression to follicular to poorly differentiated disease, some molecular characteristics appear, including gaining of certain mutations such as BRAF or RAS, in addition to TP53 and other mechanisms of resistance, such as the HER3 expression. And so this is depicted here in this schema. Also, when we focus on follicular thyroid cancer, there are some variations as far as molecular characteristics, including HRAS, but also recently described variations, including the PAX8 fusion gene, as well as a third BRAF alteration, which is targetable, as we will talk about. Most of you also have seen this slide or a version of it. This is to stress the fact that thyroid cancer is a heterogeneous disease also molecularly, and that there are actionable mutations that can be targeted. indicated here include the BRAF mutation. HRAS has been described as well and is potentially targetable too. And there remains to be non-targetable alterations as well that exist. However, the summary or the important feature here is that we do have multiple diseases with actionable mutations. It is also important to remember that these tyrosine kinase fusions in thyroid carcinomas do exist and seem to be mutually exclusive. In other words, you don't see multiple types in the same patient, indicating that these alterations or fusions are really the root cause of the cancer and should be targeted as an effective method of treating these malignancies, unlike other tumors where these fusions may coexist with other alterations. So how do we decide on when to treat a patient with metastatic disease? First, it is important to document that the patient has radioiodine refractory disease, but also it is important to look at certain clinical characteristics of this patient. Does the patient have evidence of progressive disease? Does the patient has evidence of a small volume disease or small tumor burden, or does the tumor burden appears to be large and extensive? And in either case, is the progression of disease significant? And this schema depicts a suggestion of how to move on with making these decisions. Certainly, I tend to apply this in my clinic when I see patients and make a decision on whether to initiate therapy with tyrosine kinase inhibitors. If the disease burden is small, I tend to look at the rapidity of the growth of the tumor. If this is not actually rapidly growing, I tend to hold off on initiation of treatment. If the patient has large burden of disease, I tend to be more encouraged to start tyrosine kinase inhibitors, especially if this large burden of disease is proven to be progressing rather rapidly. Certainly, if the patient is symptomatic, that also changes my decision-making as far as whether to start a treatment or not. So this presents to you the definition of what is radioiodine refractory disease. It is important to remember that this constitutes a minority of patients with metastatic differentiated thyroid cancer. It also depicts the fact that even when you start these tyrosine kinase inhibitors, you do have mechanisms of resistance that appear. Those mechanisms may include RAS, may include ALK, may include the HER2, HER3 axis, and therefore we have limitations as far as whether these medications will be clinically effective in treating these patients, even when we talk about medications that target specific fusions in this disease. This is an observation study. It's the RIFCOS trial. Some of the centers have participated in this. We participated in this, I believe. And this is a trial or an observation study that looked at initiation of tyrosine kinase inhibitors in patients upon entry versus patients who were not initiated upon entry, and compared the outcome for the two cohorts, so cohort 1 and cohort 2. And looking here at the different curves, basically you have the first curve looking at evidence of symptomatic progression. The second is overall survival and progression-free survival. And as you can see, it is not very clear as far as whether initiation of therapy in asymptomatic patient upon presentation of metastatic disease, all these patients had radioiodine refractory disease, basically made any difference in the outcome of these patients. So this basically attempted to look at whether real-world data actually would show any different results from data from clinical trials, given that most of these clinical trials allowed crossover. So to try to decide when to initiate systemic therapy, we clearly have to have persistent disease or distant metastases not amenable to radioiodine therapy. I would say if you have symptomatic disease, certainly that should be a low threshold to start systemic therapy. We have two agents that are approved in this setting for differentiated thyroid cancer. Lenvatinib or sorafenib are acceptable first-line treatments. For specific fusions such as NTRK or RET, those would require specific targeted therapies with these agents. Currently, immunotherapy has reached applications in thyroid cancer, and certainly we would consider this in poorly differentiated tumors, possibly with high mutation burden. Patients who have symptomatic disease should be considered for local therapy to control these symptoms. Certainly, if you have a clinical trial, I would consider putting this patient on a clinical trial. Let's remember also that these tyrosine kinase inhibitors do have side effects, so you have to weigh these side effects when you make your decision. To mention a few here, diarrhea and hypertension are significant side effects with most of these agents, specifically lenvatinib, causing hypertension and leading to necessitating interruption of these treatments in addition to these other symptoms. So it's clear to us that the evolving knowledge that we have in terms of understanding how these mutations work and whether these mutations are actually driver mutations such as diffusions that we described versus non-driving mutations has a bearing or should have a bearing on whether we decide to treat a patient or not. Certainly, I have a lower threshold in initiating a systemic therapy if I see that the patient has a driver mutation such as NTRK, for example, or RET mutation or RET fusion. And so I think those guidelines are bound to change the more we learn about this disease and the more we discover newer disease entities for a differentiated thyroid cancer. So to summarize, we have the DECISION trial and the SELECT trial. Those are the two studies that led to the first-line approval of sorafenib and lenvatinib for this disease. Both trials were randomized between placebo and the investigational agent. This is the design of the SELECT trial. This was a 2-to-1 randomization on the SELECT trial. The DECISION trial had a 1-to-1 randomization. Both trials allowed a crossover from the placebo arm. And you can see that both trials had significant improvement in progression-free survival, which was the primary endpoint. However, when you got to the overall survival, no difference was observed, largely probably due to crossover allowed in these studies. You notice the overall response rate with lenvatinib is close to 70%, whereas with sorafenib, it was about 12%, leading to encouraged use of lenvatinib as really the de facto first-line treatment options for these patients, with the caveat that the side effect profile of lenvatinib is not sometimes easy to deal with. Looking at older versus younger patients, this analysis showed that overall survival seems to be benefiting patients above the age of 65 for patients who took lenvatinib, and suggesting that age should not be a factor in deciding whether to initiate these treatments if everything else seems to be equivalent. So when we talk about these agents, lenvatinib or sorafenib, those are tyrosine kinase inhibitors. You know, those are the targets for lenvatinib, and you have to wonder when you look at so many targets, is this really targeted therapy because you're inhibiting multiple tyrosine kinases? And I think that has to do also with the side effect profile of these agents. When you also look at the overall outcome, you don't see, as we said, improvement in overall survival, but you see a significant rate of grade 3 hypertension exceeding 45% for these patients, leading to a pause whenever you want to decide to initiate these treatments for patients. So in my view, a treatment should not be controversial if the patient has radioiodine refractory disease and the patient is symptomatic, provided, of course, this patient does not have a contraindication to the tyrosine kinase inhibitor that you're giving. Certainly, if the patient has bulky disease, I would be more encouraged to initiate these treatments. There are some situations where we don't have measurable disease, for example, patients presenting with bone metastases, pleural effusions, and in this case, if the patient is asymptomatic if the patient is symptomatic, I would tend to say yes and recommend local therapy for these patients and initiate tyrosine kinase inhibitors for these patients as well. This is real-world data looking at sequencing of therapy, and by the year 2014, because of the approval of sorafenib, the data shows that there was a high use of sorafenib that was replaced by lenvatinib following 2015. But the important thing as well in this data is that patients continued on several lines of tyrosine kinase inhibitors, indicating that sequencing of therapy is important and could be beneficial for this disease. This is not just theory anymore. Those are results from the COSMIC trial recently presented at ASCO 2021, which is a randomized trial, again, 2-to-1 for cabozantinib versus placebo in patients who have failed prior tyrosine kinase inhibitors, 1 or 2 lines. And you can see that there was a response rate in favor of the cabozantinib, which can certainly be considered as a second-line agent for patients who fail first-line tyrosine kinase inhibitors. You can see that the 2 arms of the study, placebo and cabozantinib, were well balanced in terms of prior receiving of lenvatinib. And you can see that cabozantinib was the winner when you look at practically all of the factors that could be affecting the outcome, including prior lenvatinib, prior other agents, or age of the patient. The results do indicate improvement in progression-free survival. There was a trend in improvement in overall survival that was not significant. A reminder also that BRAF mutations do exist in papillary thyroid cancer, and this is a study looking at responses to BRAF inhibitors in 2 cohorts, patients who had prior tyrosine kinase inhibitors and patients who did not. Those are the patients who did have prior tyrosine kinase inhibitors. You get here a response rate of close to 27% compared to 38% in patients who did not. Similarly, this is reflected in a progression-free survival of 18 months versus 9 months. By the way, I would take a progression-free survival of 9 months in any of my patients with squamous cell carcinoma. So even though this is less impressive, this is still significant, I believe. An older trial basically looked at the combo versus single agent, and there was no real difference between the combo versus single agent. I think most oncologists would probably use the combo given the data that we have in anaplastic thyroid cancer using the combination that we will probably hear about later on in this symposium. Remember NTRK fusions, those also exist in papillary thyroid carcinoma, and those exist in multiple other tumors, as you can see here, with evidence of responses to therapy. 2 agents are approved for this indication, and both of them are fairly active in treating patients with NTRK fusions. So certainly when you have a fusion, I would tend to use these targeted agents such as TRK fusions or RET fusions as a first-line treatment. Otherwise, I would resort to the first-line approved therapies such as lenvatinib or sorafenib, and consider second-line therapy based on the recent data with cabozantinib. And then following this, if there is evidence of BRAF alteration, certainly we would consider that. Those usually happen in the less differentiated tumors, and certainly immunotherapy has started to being used in these poorly differentiated tumors. I'm going to skip medullary thyroid cancer because I believe it will be the subject of discussion by Dr. Wirth extensively. Similarly, anaplastic thyroid cancer, Dr. Subia will be probably discussing this at length, so I will skip this slide. Those are the ATA guidelines for anaplastic thyroid cancer, and surgery remains to be the main treatment of choice. However, if you do have a targetable mutation, certainly using this BRAF targeting agents would be an acceptable alternative as well. We talked about pembrolizumab. This is data from KEYNOTE-028 showing a response rate of close to 9% in patients receiving pembrolizumab as single agent, so not very dramatic responses. However, when you combine lenvatinib with pembrolizumab, you do see a decent clinical benefit here, reported total or overall clinical benefit of 96%, even though there was a significant number of patients with hypertension that were observed. Dr. Worth, I believe, presented this data at ASCO and subsequently at ESMO. The ASCO presentation were for patients who were not pretreated, and you can see the progression-free survival that is more generous compared to patients who were pretreated with tyrosine kinase inhibitors. So last but not least, it is important to remember that patients who, even those who receive targeted agents for these fusions, we have to be mindful of resistance mechanisms that may develop for these. There's evidence that HER3, for example, and EGFR resistant pathways play a role in resistance to BRAF inhibitors. And so we need to watch for this as resistance mechanisms may develop. My conclusion for treatment or use of tyrosine kinase in papillary thyroid carcinoma is that please check for genomic alterations. The majority of thyroid cancer patients have actionable mutations. The other important message is that a tyrosine kinase inhibitor is not for all patients with papillary thyroid cancer that is radioiodine refractory. If you look at the median time to symptomatic progression, it's about 6 years. So remember also that driver mutations are mutually exclusive. I usually have a lower threshold of starting therapy for a driver mutation or driver fusion alteration rather than a broad spectrum tyrosine kinase inhibitor. And remember that these targeted agents should be considered as first therapy if you have these alterations. And remember that the approved first-line agents for these non-fusion related changes include lenvatinib and sorafenib, and cabozantinib is very likely to be approved for second-line therapy. This is a team effort. This is our head and neck team, and many contributors here to our team that are listed in medical oncology, radiation oncology, head and neck surgery, basic research, pathology, and others. Finally, as a subsequent symposium to our symposium here, I want to remind people who are interested of our upcoming updates in management of head and neck cancer symposium coming up on November 6th, and hope to see you there. Thank you very much.